Okay, can everybody hear me okay? Okay, very good. I know it's kind of, tis the season and everybody's really busy, but I do want to put one of these out every month. So when people have time, they can go ahead and get on. And so this is just an end of the year review. So we're going to go through everything that we pretty much put out this year and then end with the case study. So um, I, what I see right now is I just see Cindy and I see Nikki, and Nikki is with education. And Cindy, where are you from?
Can you hear me okay? Can you hear me? Yeah, my mic's been acting up, so sorry. I'm from
Nope, I
medical
can't
imaging.
hear.
Oh, no?
Are you
I
talking?
can hear
Maybe
you,
have to put
Cindy.
it.
Can
Nikki,
you?
can you
Okay.
talk?
Yeah, I can hear Cindy
Oh, yep,
talking.
I am might be on mute. Huh. Hold on just a second. Technical difficulties. Gina, can you show me how to unmute this? I didn't think I was on mute, but I want to get, do I just do this? Oh, there we go. Haha, I got it. Now I can hear you. Cindy, where do you work? Thank you, Gina.
I'm in medical imaging.
Okay, very good. And
Yeah.
Nikki, you're with education. And what floors do you cover, Nikki? 9 South?
7 South, 9 South, cath lab recovery and short stay unit.
That's right. And then I just saw another person on, but
Yeah, Ashmita, she's from 7 South.
okay, very good. Well, we'll get started here. Like I said, I'm sorry, my volume was not on. So this is our pain forum. We're going to just do a review here of the last year of everything we learned and end with the case study. Okay, so our 2021 pain forum topics were naloxone kits, IV versus PO, pain assessment, buprenorphine, PCA management, ketamine, and kratom. So next year we'll be looking forward. We'll be doing a little poll to see what people are interested in hearing us talking about and putting those out. So just to start with this one, this was a big deal for our hospital. Just to remind you that SBIRT, screening, brief intervention and referral to treatment. This is a grant that we have through IDPH, and they did provide naloxone kits, which if any of you guys are up with the news, and fentanyl is spreading across the nation, people think that they may be taking street drugs such as OxyContin or a Valium or anything else, and it's laced with fentanyl. So we're having a rash of deaths again that have increased. So hopefully you guys have all seen, and speak up if you have questions, but you've all seen the naloxone kits. How this works is the provider or the nurse or the pharmacist can go ahead and do this. They can order this for discharge. It comes up from the pharmacy. There are 2 naloxone kits. They come with instructions. The big thing for nurses that we need to know is we need to do education with the families or whoever the patient resides with. So they know if the patient goes unconscious, they know how to do it. So this is free to the patient. Some reasons why we may want to do this: if their oral morphine milliequivalent is above 50, or they're new to opioids, if they use benzodiazepines or other sedating medications along with opioids, if they have a history of substance use disorder or a psychiatric disorder with opioids, this would be great. And then also, obviously, if they've ever had a current or past overdose, this is a great medication. And I will tell you that I've given it out before to someone who gave it to someone else. That's fine. We want to get these out. They're free. So how you document it, I'll let you guys go ahead and look how we do this. So you just do chart not done. This allows the nurse to document that the patient received the kit and that the education was provided, that we actually didn't give the medication to them physically, but we did do the education and give it to the patient. So you can see the different information here that is available. on what we want to talk to the patient about, how to recognize the symptoms of an opioid overdose. Most of the time, that's pretty easy to tell, but it's nice just to go over it with whoever's going to learn how to do this. How to administer the Narcan nasal spray. Instructions are on that, and then how to proceed if the person regains consciousness before help arrives. So that does also encourage them to call 911. I'm going to back up there. Anybody given this to any of their patients that's on?
I haven't, but I know some of the staff have done this in the past.
Okay, I will tell you, we have hundreds of these. So if people, I mean, I feel like every day I bump into at least 5 people that would need this. So as nurses, I'm encouraging it to be ordered. And please try to encourage providers to order this, as it's free and it's a great service that Mercy provides. Okay, IV versus PO. This is a big thing. It's a big topic. I feel like we have just done an amazing job. Danica would probably agree that we have been doing a much better job at not giving IV and PO together, but oral is always the preferred route of administration for opioids. We need to start low and go slow. Just a point of conversation here, you can use the PAS score on any patient to trend their sedation levels. So does everybody know about the PAS score? It's the Passero opioid sedation score. So we use it mostly with our PCAs and epidurals. But I also think that it would be great if people are opioid naive or we're worried about their sedation levels, if we start trending these as well. It just shows a lot of critical thinking on the nurse's part to say, I recognize this person may be high risk with the medications they're receiving, and I really want to trend their sedation on top of doing their O2 sat, as we know that is a late indicator of respiratory distress. But vital signs is also very important. So always document your reassessment of pain. I want you guys to know that this month, Danica and I started doing assessments on all floors. So we're doing 10 assessments on every single floor, just random assessments to see how we're doing on number 1, pain assessment on admission, and number 2, pain assessment with every shift, and then most importantly, our reassessment of pain. So far we've seen a pretty good response. So I think that there is always room for improvement with everything, but remember, when we reassess pain, it's not only good that the patient gets that done and that you have communication with the patient, but it's good for everybody that looks in the chart to see that the interventions and the medications are actually helping. So stay on top of the pain. Sleeping does not equal no pain. I will say there were 2 trauma patients this week that did not receive their Tylenol that's scheduled every 6 at midnight, and the comment was patient was sleeping. That is not probably the best option, as the patient then the next day is in a lot of pain as they're trying to do their activities. So if you do have someone on oxycodone every 4 hours and they're sleeping, you need to wake them and ask them if they need anything for pain, and maybe even encourage them for at least 24 hours after surgery, as we do know that oxycodone only works for 4 hours unless they're elderly with a slow metabolism or have kidney problems. When giving an opioid that is not in the range on the order, please document why. Okay, so this is a big thing. I know I've talked to multiple people about this, but when you have a patient that says that their pain is a 3, but they are facial expressions of pain, and they're not wanting to do their PT, and they're not wanting to move, and they're just miserable, you can give the higher dose. You just need to document why. We don't want to give the pain medicines according to the scores. I know that sounds kind of backward, but the scores are just there because we have to have them for Joint Commission. We need to treat the patient. So if we know they're going to have physical therapy and they say their pain's a 5 and they look fine, we may give them a 10 because we know that we want them to do their physical therapy. Or on the other end, we all know that the patients that say their pain is always a 10, and I kind of, do say this a little bit, but they're on their phone, they're eating their Doritos and drinking their Mountain Dew, and then they say, we ask them how their pain is, their abdominal pain, and they're like, it's a 10, it's a 10. And then they get right back on the phone. We also know that we need to use our best nursing judgment in that way as well. Pain assessment. I love this little scale. It's a Lego pain assessment tool. So if you've ever stepped on a children's toy, you know how that feels. But we need to remember that pain is what the patient says it is. And then we have to use our critical thinking and nursing judgment to make sure that we give them the pain medication that they need. So different pain scales are the numeric, the Wong faces, the pain AD. If you guys don't know about that, I'm working with IT right now to get that into our system. So that's basically a pain scale for advanced dementia. Has anybody used that? I know on the floor, Danica and I will hand that out when nurses have patients that have delirium or dementia, to make sure that we're not just looking at their facial expressions, but we're also looking at, are they stiff in the bed? Are they squeezing their sheets? We need to look to make sure that we're really doing a good pain assessment to get them what they need. And then the functional pain scale, you'll see Danica and I's note always includes the functional pain scale. It's really important to know, is the patient able to function? A lot of times what we do is we do give pain medicine, and one of the goals obviously is that they can become more functional and work with physical therapy. So components of pain: location, description, intensity, duration, alleviating and aggravating factors, associated factors, impact of pain on patient's life, history of pain, activity and function, and bowel movements. These are all important things. And I know that on with the fast pace of nursing right now, we look at everything that we can document. If you could even do some of the teaching with pain, or maybe even the location would be awesome, because a lot of times what happens is post-op patients, they say their pain is 10/10, and we're giving them a ton of oxycodone, but then I go to see them and this is their chronic back pain that they don't take oxycodone at home, and their surgical pain is actually a 2. So we also need to remember to chart where it is and make sure that we are medicating for the right pain. So documentation, like I talked about before, pain scores prior to and after the dose, and then of course education around pain medicine. Updating the whiteboards. I feel like the whiteboards have been looking a little bit better lately, but a lot of patients, I always say, they're not professional patients if they think they're getting oxycodone every 4. They don't know they have to ask for it. Sometimes they'll go 12-13 hours with nothing and just figure the pain medicine isn't working. Buprenorphine. So once again, let me go back to that. Anybody have any comments about pain assessment? And we've got some more people on here. We have Emily. Emily, where are you from? And we have Heather, and I think Heather is 9 South. Right, Heather?
Starting Sunday, I will be.
Okay, very good. And KDV?
I'm on 7 South.
Okay, perfect. And Pam C? Anyway, you guys can put it in the chat where you're from, but now that I know that Heather's on the phone, I do have to give out a shout out to Heather. Every time I do an assessment, and actually I gave a shout out to her, who I thought was her director, because she was working on 6 North, but I will say, Heather, just personally, when I look at your pain assessments and your charting, it's just very good. So kudos to you. Keep up the good work. And please share what you do with others, because it does make a big difference for the patients. Okay.
Hey, Jen,
Yes.
I do have a question regarding pain assessment.
Yes.
Can you kind of talk through what it looks like when we're trying to set a goal for somebody's pain, especially like in the surgical world?
Sure.
We're really probably not going to get them to 0. So what kind of verbiage can we use to help with our patients, help them
Yes.
understand that?
Good question. So when you're talking about goals, usually, and you'll see Danica and I also put a functional goal for the patient. Make the goals obtainable and make them realistic. So when you're talking about pain with a patient that's going to go to surgery, a lot of times some of the language I know that Joint Commission recommends is realistic pain goals, and that the patient is part of the conversation for their goals. So if you're getting someone that is from a nursing home and doesn't get out of bed and doesn't walk, the right goal probably is not to get up and ambulate after surgery, but maybe it's to turn in bed with tolerable pain. So I think it has to be patient specific and obtainable. And once again, you know, we can ask patients, is it okay for them to say they can tolerate zero pain? Absolutely. But then we have to reassure them that we're going to help them work through with both medications and non-medication options. We have our comfort menu. Hopefully most of you guys have seen that, with comfort carts that were developed in 2018 after some regulations by Joint Commission. But this is a great way. You would not believe, and people will roll their eyes, and you may roll your eyes at this too, but music therapy, letting them listen to the music that they like, having the lights on or off, having coloring sheets, distraction items or puzzles, all those things matter. And even having your teeth brushed matter. And I know that that sounds silly, but being clean and feeling good about yourself matters in pain too. So that's a good question, Nikki. And I just want everybody to know, if you guys ever have questions about that, you can call Danica and I, and we can assist with that too, because it is important that the patient does have a realistic and appropriate goal. Okay, on to buprenorphine. Just a question. Who feels comfortable with buprenorphine? Anybody? Who's
What's
kind
the
of
oth-
scared of it?
What's the other name for it?
Suboxone.
Ah,
So buprenorphine is a great drug. We use it not only for substance use disorder, but we also use it for pain control. So it's a mixed agonist, okay? So it can block the mu receptor, but most of the time up to about 12 to 16 milligrams, we can still use a pure agonist such as morphine or oxycodone, Dilaudid. Those will still work with the buprenorphine on board. But the big thing that I want you to think about when someone has buprenorphine is it can block the mu receptor. Okay. I'm going to give you an example here in a little bit. So it's metabolized in the liver, it's excreted in the bile. It has a sealing effect on respiratory depression, which is great because it's the only opioid that does that. So we're not going to have respiratory depression. It has less GI side effects, especially with the constipation and nausea. And I don't know if anybody on 8 South is on here, but we know that that is like a given when we get into the high opioid doses. So its activity is at the kappa receptor, and it yields anti-hyperalgesic activity, anti-euphoric, and it decreases sedation. It's excreted in the bile, like I said, so you can use freely at all levels of renal dysfunction. It's not associated with increased risk of fractures in the elderly, which is good. And you don't need a functioning GI tract to administer it because we do have transmural and we also have IV available. So a few other things. This presentation was given by Dr. Goldman. But from Meller Davis, the final 6 reasons to choose buprenorphine, and this is for cancer patients. It's not immunosuppressant like morphine and fentanyl are. It does not affect the hypothalamic pituitary adrenal axis, and it does not cause hypogonadism. It prolongs the QTC, but it's mild. So it's 100 times less risk than methadone as far as the QTC elevation above 500. So no monitoring or EKG is needed. It's safe and effective in the elderly. It's the safest of all the opioids in renal failure, and it is not cleared by dialysis, which is crazy because I know we think about that a lot. Withdrawal symptoms are milder and the drug dependence is less. So you can see down below when we think about sublingual buprenorphine down at the bottom, it's equal to 80 oral morphine milliequivalents. So that should kind of make your head spin. That's a lot. That's a lot of opioids. So normally when we see people on buprenorphine for pain, it's going to be the higher doses, like we're talking like in the 200 oral morphine milliequivalents a day or more. When we think about buprenorphine or Suboxone for MAT, for medication assisted treatment for substance use disorder, we recently had a patient who came in. He was going to have a complex spine procedure. He had been on buprenorphine for like 8 years at higher doses. He did not take it that morning. No one talked to him before, after surgery. So he was on high doses, right? So it's blocking the mu receptor. So he goes through surgery with his mu receptor pretty blocked. I think he was on 32 milligrams, so a lot. And they called me. It was on a Friday. I wasn't at work, but they could not get his pain under control, which is correct. So I recommended that we did a PCA. The next day I called to check on him and they said the PCA didn't work and they put him on tramadol. So hopefully you guys your ears are perking. Tramadol is not even close to what this man needed. And he finally left the hospital so he could get his buprenorphine. So any comments on that one? That one, hopefully, if you have a patient on buprenorphine or methadone, you need to call us to make sure that they're getting these. These drugs are very high opioid doses. Withdrawal is really real. And the biggest thing with buprenorphine is it can block the mu receptor. So opioids, you have to have high doses for them to work. Any questions on buprenorphine or comments? Okay. Next one is PCA. We also, Danica and I, do PCA and epidural audits. So what we're looking at is documentation, which we'll go through next. But indications for PCA is acute pain, trauma, post-op pain, acute medical disorders such as pancreatitis, oncology, and then MPO status. Some contraindications are inability to understand how to operate the PCA. Also, if they can't push the button, we recently had somebody who could not physically push the button because her hands were so swollen. Basal rate is not recommended. Okay, so basal rate just keeps going and the patient is not giving it. So one of the safety methods of the PCA is when the patient gets too sleepy to have more opioid, they're not able to push the button. If a basal rate is going, it just keeps going, whether they're sleepy or not. Some other contraindications are decreased level of consciousness, respiratory distress, and of course, allergies. Side effects are nausea and vomiting, constipation, itching, confusion, respiratory depression, and urinary retention. So these are all very common with opioids. Documentation, this is really what I wanted to go into here as a good reminder. So on pain resources in our share drive, you'll see these documents. So you can go ahead and pull these up if you have a PCA, a ketamine PCA, or a epidural pump. So you can go ahead and you can pull these up and look at them and you'll know exactly how to chart. So the initiation of the PCA, 1 hour after it starts, and then every 4 hours for the duration of the PCA. So whether you have the patient starting it or you're getting them when they've already had it. And then once again, the end of shift minimal, the cosign, and then discontinuing the PCA. So any questions or comments about this? Do you guys all know how to get on the share drive and find the pain resources? It's a great area with great resources. If you ever want resources that aren't on there, please tell us. We'll be happy to develop them. And hopefully you guys have noticed that Danica and I put PCA directions on every PCA pump. I know we've had a lot of comments that people are happy with that, how to set up the PCA. And then this year, Gina and I also did a video on how to clear the PCA pump and how to get the 24-hour total. It's a really quick video. We did how to set it up. So that's also on the pain resources. So if you're like, oh my gosh, I haven't done this in a long time, or I'm going to go in and I don't want to feel like I don't know what I'm doing, just watch the video or pull the video up in the room and pause it. It's a great way to keep up. So ketamine, who's had a ketamine infusion yet on this call? Anybody?
I did on 6.
Oh, good. Heather, how did it go?
It actually went pretty well. I never had done ketamine before, so it's an interesting learning experience.
Good. Tell me what about the patient? What was the indication?
I do not remember the details right now.
That's okay. Were you nervous?
A little.
Okay. And that's okay because it's a different kind of medication, right? So ketamine, again, works on a different receptor. Indications for ketamine are spinal fusion, sickle cell, opioid dependence with acute pain, traumatic injury, postoperative pain. We've been doing a lot of it on post-op amputations, and oh my gosh, and vasculars. It's making just such a ginormous difference. Another thing that we're using ketamine for is people who are opioid dependent and coming in for acute on chronic pain. For many years, they're used to coming in and getting Dilaudid. We're doing ketamine instead and keeping them on their same opioid regimen, and it's actually decreasing those people coming into the hospital. And we never want to assume that somebody is trying to get extra opioid because of addiction, but it does happen. So nursing assessments, we want to do the same as we do for PCAs. Okay. So everything you're seeing here is just the same as the PCA. We're going to document the same as the PCA. Side effects, they can have hallucinations. I've had people see like pink elephants. I had a woman say she saw her fork walking across the room, but they can have delirium, vivid dreams. That's usually as the dose goes up. So what we need to do as nurses is be supportive, talk them through that. We have Ativan if they need it. They can have nausea and vomiting, excessive salivation. I haven't seen any of that. Hypotension, bradycardia, tachycardia. I think a lot of that is at the higher levels. Respiratory depression, of course, can happen with increased amounts. One thing I do want to say, just so you guys all know, you can do a PCA and a PCA opioid and a PCA ketamine. They work differently. Okay, so that's all right. Kratom is the last one I want to go over here. Dr. Filippelli, who works at United Community Services, talked about Kratom. Has anybody heard of Kratom on the call? So Kratom comes from like head shops and gas stations. So Kratom can cause effects similar to both opioids and stimulants. At low doses, users report increased energy, sociability, and alertness instead of sedation. Two components of Kratom leaves. There's two different components. They interact with opioid receptors in the brain, just like morphine or oxycodone. They produce sedation, pleasure, they decrease pain, especially when users consume large amounts. There have been 44 Kratom overdose deaths that were reported in 2017. We all know that data is old as they have to get everything together, and Kratom is a new thing that they're looking at. Kratom can cause dependence and addiction. Signs of withdrawal you can see are muscle aches, insomnia, irritability, hostility, aggression, runny nose, jerky movements similar to opioid withdrawal. Reported health effects are nausea, vomiting, itching, sweating, dry mouth, constipation, increased urination, loss of appetite, seizures, and hallucinations. So currently Kratom is legal in Iowa, but it's illegal in 6 states so far in the United States. And we really hope that we can start a motion to get it illegal also in Iowa. Any questions about Kratom? I like that because we should know that it's not just marijuana, meth, heroin, but there's other things out there such as kratom. And if you have kids, this is something to inform them of too. It's not good. And unfortunately, you can get it at the gas station. So we're not going to have time to do our case study, but I do want to remind you, we do have resources on the share drive under pain resources. We have PCA, epidural, ketamine. We have pharmacology resources. We have non-pharmacology resources. We have pain scales, withdrawal skills. We have these recordings, the pain forum recordings. We have comfort menu resources, lidocaine infusion resources, which are only in the unit right now. We have a pain and opioid stewardship committee, and you're welcome to see all those notes. And then screening, brief intervention, and referral to treatment resources as well. And that's the expert team. Okay, any comments? I know that we're right on our time, but any comments or questions?
I have 2 questions, Jen.
Yes.
One being, why would someone need to be on both a morphine PCA and a ketamine PCA? What does that look like? Why would they need that?
Okay, yep, because opioids work on the mu receptor, pain receptor, and ketamine, I'm probably gonna say this wrong, the MB, can you look that up real quick? It's like MBK receptor, it's a different receptor that it works on as far as pain. And so combination together, they make a really good fit for pain management, where a lot of times when opioids alone are not working, we can add ketamine. What we don't want to do is stop the opioid when it's at a higher dose and only give ketamine, because then that's a failure in the ketamine. So it's just an additional medication. It's multimodal, such as adding like gabapentin or adding a muscle relaxer.
Got it. That makes sense.
Mhm.
And
But
then my second, go ahead.
no, that's a good question.
Yeah. My second question is, you mentioned lidocaine infusions in the ICU. Is that for pain management? Okay.
Yep. So they're doing it for 6 hours. Sometimes they're doing it after complex spines, but right now they're using it a lot for complex abdominal surgeries. So
it.
actually, just to put a little birdie out there for you guys, we are having a pain conference in May, and Dr. Franco is going to be speaking about lidocaine infusions after surgery. So
Interesting. Okay.
did you see the receptor? Oh, and Danica's got the receptor. Yeah. What is it? But what's the letters? NMDA is the receptor that ketamine works on. Okay. Any other comments or questions? Okay. Once again, thanks for a great 2021. We hope that we can continue to serve you guys with everything that you need in 2022. Have a happy holiday, everybody.
Thank you.
Thank you.